Good morning, everyone. It gives me so much joy to see this room so packed after we've been planning this for so long, so thank you. To introduce myself, I'm Professor Catherine Hill. I'm a rheumatologist from Adelaide. I'm Deputy Chair of the Australian New Zealand Vasculitis Society and co-convener of this International Vasculitis Workshop. And I'm here on behalf of the wonderful Community and Patient Conference Organising Committee. Firstly, I'd like to acknowledge the traditional owners of the lands and waters throughout Australia and pay my respect to the elders past, present and emerging. We recognise the importance of connection to culture, land, kinship and community to the health and wellbeing of Aboriginal and Torres Strait Islander families. We acknowledge the cultural practices and traditions still carried out today and being passed down to future generations. We are an international community today, so we also recognise and celebrate the richness and cultures and traditions of people all over the world. We honour the diversity of background, experiences and identities that make up our global community. So after that, I'd really love to introduce Luke. Luke's visiting us from New Zealand. He's a patient living with vasculitis and he's going to give a Maori welcome for us.
Can you hear me okay? My brother wrote this for this conference, so I'll read it and I'll summarise it. It's just an acknowledgement. Uia ki te rangi te iho nei, uia ki te papa e takato nei, uia ki te pō, uia ki te ao. Tākere ko te wai, he wai rere, he wai rangi, he wai nuku. Tā māua ki te wai aro, ki o wai mau, tā māua ki te wai oro, ki o wai o. Te māua ki te wai ihi ki a wai tau. He wai ka nuku, he wai ka neke, he wai tupua, he wai tāwhito, he wai ariki, he wai ora. Tō ana koe ki te wai, ka ora e, humi e, hui e, tā ki e. So we all have gathered from their lands and guided by those who come before us into a shared space of purpose, like the many waters that flow from the sky and earth. We bring together patients, family, health professionals as one. We acknowledge those who have travelled from near and afar. Together we share this space to learn from one another. Thank you all for being here today. Tēnā koutou.
Thanks so much, Luke. So I want to welcome you today to this conference, which is being run in conjunction with the 22nd and International Vasculitis Workshop. This workshop is run every 2 years and it's run in international locations, and for the very first time it's being run in the Southern Hemisphere by the Australian and New Zealand Vasculitis Society. I'd especially like to thank our sponsors for this Community and Patient Conference today, Alexion and the Vasculitis Foundation. So the workshop runs from Sunday to Wednesday. We've got over 60 international speakers, some of whom are talking with you today. And over 1,000 healthcare professionals and researchers who are keen to improve their knowledge and expertise in vasculitis. In addition, we're running an education course this weekend, and there's over 500 healthcare professionals who want to learn more to improve the care of people with vasculitis. So I think this means, I'm telling you this to show you that there's many healthcare professionals who really care a lot about these illnesses and want to improve the way they care for you. We've put together a program today with a wonderful group of people, and I want to acknowledge them. Diane Purdy, who's from New Zealand, who couldn't join us today, but she's given us an amazing amount of help. Mark Street, Tze Goh, Gabby Venter, Emily Sybrin and Joyce Coleman. They've offered us a wealth of personal and professional experience of vasculitis. I was wondering whether you guys could stand up and wave your hands. So if you need any help or you have any questions during the day, please approach one of us. If you have a look at the program, there are 2 plenary sessions, and this is a plenary session where we're all in together. So this is this morning and towards the end of the day after 3 o'clock. And then we have 3 breakout sessions. So there'll be one session in this room, and the other 2 will be in the courtyard rooms, which are just outside on the right. So if you have a look at the program and decide which one you want to go to, And if you're not sure, just ask one of us about which one. It is important to remember, though, the one that will be going on in this room will actually be videotaped, and so you will have the opportunity to look at that later. So maybe that will influence which one you decide to go to. Those will be available through Anne's Vasc and the Vasculitis Foundation. The program today has been designed to be informative and practical with plenty of time for your questions. So each session will finish with a Q&A session. But please remember, in this setting, our speakers can only give general advice and are not able to give individual medical advice. Some of you have already submitted questions online, so thank you for that. And the relevant moderators have been sent those questions. So my first rule of order is to introduce Dr. Tze Goh. He's a renal specialist based in Auckland, New Zealand, with an interest in vasculitis and kidney disease, in particular ANCA-associated vasculitis. He collaborates closely with his rheumatology colleagues within a combined rheumatology and renal vasculitis clinic. Thanks, Tze.
Hi, good morning. Thank you for giving me the chance to talk to you about the basics of vasculitis today. So my name is Tze. I'm a nephrologist, which is a fancy term for a kidney doctor, and I'm based in New Zealand. But part of this talk, everyone's journey with vasculitis is very different, even if you have the same type. Like if you call it GPA, your journey is just so different. So it's very likely that the talks that you hear today is quite general, so some of it may not actually be applicable to your individual cases. I also like in my talk to try and clarify a few terms that we doctors tend to like to use, so hopefully that would help you understand your disease a little better. So we start off with what is vasculitis. So vasculitis, if you boil it down, really is just inflammation of blood vessels. And you imagine we've got blood vessels everywhere, and depending on what type of vasculitis you have, affects different types of blood vessels in different organ system, which is why you see such a wide variability in how people present. The vasculitis can occur by themselves, and we doctors sometimes call this primary, or can relate it to another disease, which could be infections, which we kind of call them secondary. A lot of what I'm saying today is going to be more applicable to the primary disease, because the secondary disease, we have a tendency to try and treat those. I wouldn't be able to go through the exact mechanism. It's a bit complicated, but if I were to simplify it, it basically boils down to dysfunction of parts of your immune system. And different vasculitis have different dysfunctions, and hence that's why they affect the body in different ways. Your immune system is designed that it should fight germs and recognize things as being outside and never attack yourself. But in vasculitis, for various reasons, this is dysregulated, and hence you get your body attacking your own blood vessels and organ systems. We like to group vasculitis into, often based on the size of the blood vessels. On the picture on the right is what we call Chapel-Hughes consensus, and you could see that we're separating it by the blood vessel size. We got, for example, ANCA-associated small vessel vasculitis, and affecting kind of the smaller blood vessels, and similar kind of overlaps in terms of location in immune complex small vessel vasculitis, including cryoglobulinemia. Anti-GBM is like a very small blood vessels, capillaritis, and then you got the large vessel vasculitis like Takahashi and giant cell arteritis. However, though, some doctors might like to call vasculitis based on the organ system. So, for example, you might hear things like renal limited vasculitis. The symptoms of vasculitis is varied. Now, the picture on the right is just to show you the potential organs that may be affected. It doesn't mean that you will get all of them. In fact, majority of you should not get all of them. But it just tells you of the wide-ranging possibilities of the different types of vasculitis. And also the picture is not exhaustive. There are actually other types of manifestations that might occur in vasculitis. In general, most people would, however, have general symptoms of tiredness, weight loss, lack of appetite, and often joint pains and skin changes. Then depending on what type of vasculitis you have, in this case I've used the example GPA, then it's very common that you have kind of nasal or ENT involvements with that. The diagnosis of vasculitis is very challenging, and it is fairly common to have delays in diagnosis, especially if you present to more of a generalist. It is a rare disease, so it's not a very easy one to diagnose sometimes. Very important mimics are things like infection, cancer, both from the point of the fact that before we diagnose vasculitis, we need to be sure that these are not the other diseases because their symptoms overlap, but also similarly that if someone has presented and you've done exhaustive tests to exclude infection, cancer, vasculitis should be in your thinking. You have gone through multiple blood tests, urine tests, usually scans, and sometimes people would also be recommending more invasive tests like biopsies. So in terms of treatment, it often involves kind of suppression of your immune system. In vasculitis, it's very severe at the beginning. It can be very intensive. The aim of that part of the treatment is to try and get the inflammation under control, stop the body from attacking your organ system. And when we got the inflammation under control, we use a term called remission. In vasculitis types that can come back, which we call relapse, once the disease is in remission or under control, then the aim of the treatment at that point in time is to prevent it coming back. We are always balancing between preventing damage from the disease and also the toxicities of the treatment that we're giving. In particular, things like glucocorticoid, we would like to reduce that as much as we can. And sometimes that balancing act can be quite difficult, which is why your treatment regimen may be quite different from another person with vasculitis. This slide is really a kind of like introduction of some of the other talks that you would hear throughout the day, because beyond controlling the vasculitis, which we have a tendency to focus to, there's a lot of other things that come into a patient's life. Things like mental health, fatigue, infection, vaccination, traveling, how do we monitor for disease, the importance of diet and exercise, in long run, things like cardiovascular disease. You've ended up with permanent kidney damage. What should we do to preserve the remaining kidney functions? And it's also very important, depending on, not everyone's variable in their country where they come from, but we always strive to try and provide the most up-to-date treatment within our own healthcare system, and this is where we collaborate as much as we can with patients. And it's also very important to have research. We really love to have patient involvement in research. So with that, I'm going to stop, and I'll pass you to Professor Merkel.
So it's really my pleasure to introduce Professor Peter Merkel. I've known Peter for over 25 years because I did my research training in Boston, and he was a junior consultant then, but he hasn't changed a bit actually. He's now Professor of Medicine and Epidemiology and Chief of Rheumatology at the University of Pennsylvania. He's the principal investigator of the Vasculitis Clinical Research Consortium, and he's a leading expert in clinical and translational investigation. His work is supported by multiple research grants focusing on advancing vasculitis care. And we're really lucky to have Peter today because he's really one of the global experts in vasculitis. And so thank you, Peter, for talking with us today.
Well, good morning. What a great crowd. It's wonderful to see so many patients and your support team with you today. I really want to thank Catherine and the whole team for asking me to come. I love speaking with patients. I love working with patients. It's what we do. It's what we're meant to do. And I learn a lot from your questions and from what to do. And they feed my ability to treat people better and work with you, as well as the research ideas. You're going to hear more about that. You have a little goodie bag from the Vasculitis Patient-Powered Research Network, which I direct along with Dr. Jennifer Gordon, who you'll hear from later, a patient partner. And definitely some of the work we do directly comes from questions that patients have asked. So it's terrific. I'm here to give you the strategies for management of vasculitis, which is a daunting, vague title. I'm going to put my timer on here because Catherine will cause me great harm if I go over. And so, and I think part of what we're trying to do is prevent damage, as we say, in vasculitis. And so this was to go give a great intro. You're going to hear some overlap because the concepts are important and repeating it is important. I was asked to talk about management in general, so clearly not going to talk about specific therapies. That's coming later in the day. You have breakouts for that, for individual things. invariably, someone will say, you didn't cover my disease, you didn't cover my management. But I think the idea is to leave today, I think this conference, feeling much more knowledgeable about the whole approach. And as you read and look at your own and talk to your physician at the same time, you'll understand things in context better. And that's the goal here today. At least that's my goal. Let's see what I can do here. Okay, I have a lot of disclosures. I work with a huge number of drug companies, and I take tax dollars from every government possible to do some of our, including I've done it we've taken it from the Australian and New Zealand governments as well that do work to develop drugs in vasculitis, scleroderma, and other autoimmune diseases I study, and we've successfully done that, and so we'll do that. We'll continue to do that. So what I hope today is to give you a broad overview to help set up the rest of today's program. You've already, part two, I should say, from part one you just heard. I'm going to use the term key concepts. What are the key concepts that I think a patient with vasculitis should have in his or her head to think about moving forward? The diagnosis of vasculitis, cataloging the extent of disease, healthcare team, initiating treatment for vasculitis, the stages of treatment of vasculitis, monitoring vasculitis, and addressing additional aspects of health. Education and self-advocacy, you've already started that. Good job by being here. And putting it all together, which is hard. So on the right, you might think is from a famous painting, but actually that's a picture of a patient when they first get told they have vasculitis. And so it is really, because it's like, what are you talking about? And it's scary and it's weird. And as I like to say, I don't like to, but I say often, which is, these are all rare diseases. A disease is rare until you or someone you love gets it. And then it's not rare anymore because now you're living with it and you hear about it all of a sudden, oh, that person has vasculitis, oh, cousin Minnie has vasculitis, and you hear about it. But it is scary and it's hard to move forward. But I think the diagnosis, the key concept is arriving at a specific diagnosis of vasculitis matters. We have 15 plus types of vasculitis. But it's not always possible. Some of you here probably have what we call SSV, which is some sort of vasculitis, and it's not exactly clear. And it's not laughing, it's real, which is, but as I sometimes say to patients, I'm not sure what you have, but you're in the right office, and we need to narrow it down. Over time, it sometimes becomes clearer. Delay really is we've actually published data through our VPPRN and others that the delay can be weeks, months, and even years for some forms of vasculitis, and we have to fix that. There's a lot of, there's a range of certainty. How certain are you have this vasculitis? Definitely, probably, possibly, or it's not vasculitis, which is usually a good thing unless it's something even worse. Sometimes, as I said, it's some sort of vasculitis, and we work on it from there. There are different types of vasculitis, have very different manifestations of disease. So someone with giant cell arteritis, headaches, and maybe involved in the aorta is very different from someone with eosinophilic granulomatosis with polyangiitis. By the way, we try to make things as polysyllabic and complicated as possible. I hope we've achieved that. And we actually, 10 years ago, started changing the names for good reasons, but to make it hard. And we use a lot of abbreviations, so please ask for that. There's different prognosis. Some are very severe up front, some mild, and even within the diseases. Treatments vary greatly. That's good. Treatment used to not vary. Now we have better array of treatments for different types of vasculitis. That's a success. Monitoring is different for different types of vasculitis, and you need to know what it is for your type of vasculitis. And the impact on your lives differ greatly based on what has happened or what has not happened, what drugs you're on, where are you at in life, and these are all factors to consider when you're thinking about what's going on. Always reconsider the diagnosis if it's not going the way it's supposed to go. So this is a humbling medicine. It should be humbling. We should know what you don't know and reconsider what's going on. I'm not saying that you shouldn't count on your diagnosis, but there are times when you may have to rethink it. Or more commonly is maybe it's not vasculitis that's causing whatever problem I have today. Maybe it's, unfortunately, seems incredibly unfair, but just because you have vasculitis doesn't mean you're not allowed to get everything else people get. And so it can be hard to sort that out, and that's where we work together to figure that out. And everyone else, all your other doctors other than your vasculitis doctors or nurses will be saying it's vasculitis. They always point to us. And the answer is, you know what? It's not always us. It could be an infection, it could be something or worse. As I say, we want to hear from you, but if you smack your knee against the desk and it hurts, it's probably not your vasculitis. But if your knee's hurting for no other reason, I'd like to know about that. And so common sense. But often people look to vasculitis and they want to say that's what it is, but it may not be. All right. So consider other medical issues. I'm going to keep. Now I'm already behind. See, I know he was quick, man. I'm going to use some of your minutes. So cataloging the extent of vasculitis. So I think this is about staging. Why is this important? There's a key concept, which is you need to know what you start with. And later, you need to know where you're at if you have a relapse or other things. Why is it important? Because we want to treat whatever's going on, and you want to know what, I call it staging, and et cetera. You need to know the extent when you're starting therapy. Extent and severity may impact the choice of therapy. Some things are worse than others. And sometimes we have different therapies for different aspects of disease. We don't have that a lot, but sometimes. You need to know what's new, and you need to know what's old. Because if that nodule, I don't know if I have an example, so if you have a nodule in your lung and it scars up, I need to know that in 2026, that was there, and it's still there, 27, so that in 2030, if you have symptoms and we take another CAT scan and we see it, we could say, you know what, that's not new. We don't have to treat that. But if it wasn't there and now it's there, it's good to know. So you want to reestablish where you're at. So we do all these tests, you get a baseline, you get treated, we recatalog, we do it again. You know what it's like? We do this in cancer, restaging cancer, and people don't think that's odd. It's not odd in vasculitis either. You need to know where you're at different stages. That doesn't mean you need CAT scans all the time, but you need to know. So the different types of vasculitis have different staging. These are just some examples. In ANCA-associated vasculitis, you get a hearing test, you might get head and chest CTs, you might get labs or a biopsy. While in giant cell arteritis, you'll get a biopsy or you'll get some imaging, or you'll get labs. Tachyosteitis, you're certainly going to get an angiogram of some sort. That's the only way to follow that disease. You might even get a PET scan. We're using those a lot more, at least in the US. And specific types of vasculitis have other things that you'll follow because there's a large, varied group of diseases. You need to know what it's like for yours. And in addition, you're going to do, of course, the full medical history and physical exam. And these are all ways to stage disease. So the next key concept is your healthcare team. You need a team that works for you. So you need the right people for you on your team. And that will depend on what type of vasculitis you have, what manifestations of disease you've had, who you are, who you're comfortable with, where do you live? What's my access to things? How many resources do I have to be able to? Can I fly to Melbourne every 3 months from where I live in the middle of the country or not? I'm not saying you have to do that. I'm just saying those are the things. You need someone who's your primary. I should have used the term, actually I prefer to use the term principal. Who's your principal provider for vasculitis? Much of the time it's a rheumatologist. I'm a rheumatologist, so I tend to be more rheumatologist. Although I really love nephrologists. As a matter of fact, I married one. That's dedication. That is dedication to multidisciplinary care. And so, have you gone that far? I just want to know if you've gone. Anyway, so, but it might be a nephrologist. It might be internal medicine in some countries. Not here, but in some countries, internal medicine means something different than it does here. And it could even be a neurologist or a pulmonologist, et cetera. You may certainly need these other people to help follow, but somebody needs to be the person who is helping to direct things with you. So there aren't too many different voices. You need to have really good communication. The best tool for physicians isn't necessarily typing something in the chart. It's picking up the phone and talking to somebody else and making sure we're communicating about you and with you as well. You should have a primary care provider. Is that a term you use here? General practitioner. You need what? Or a nurse practitioner, absolutely. And actually, upstairs is a nurse practitioner I work closely with for the last 15 years who knows more about vasculitis than almost every other physician on the planet. So your general practitioner needs to be involved because the vasculitis folks and the nephrologists and rheumatologists, we don't take care of everything, and we're in a lot of demand, and so you'll be able to have that. But that person needs to not be scared of your vasculitis, but they need to know how to use a telephone and to contact us if there's a problem. And so I think that communication is key. All right, So do you go to a major center or do you go to an academic center? So there are vasculitis centers, which is a subset of academic centers, which is a subset of all the doctors, or do you stay with your local doc? Co-management may be appropriate for you. Often we do that a lot. Some people just will come to the major center. They'll go to, if they live in Adelaide, they'll see Dr. Hill and her team, but they may see you regularly, or they may see her once a year, and she'll communicate back and forth with somebody else. That's co-management. You just have to figure out what works for you. Different approaches work in different places. So, moving on, initiating treatment for vasculitis. So, most cases of vasculitis require treatment. So you could say, are there any that don't? Occasionally, there might be a drug-induced something, or there's IgA vasculitis that happen, especially in young people. It comes, we watch it, and it goes away. It's when it doesn't go away that it's a problem. So most cases require treatment. And so vasculitis is usually initially treated with drugs to suppress inflammation and the immune system. Think of it as putting the fire out and, as you heard before, turning down the immune system. So it's a little bit of the Goldilocks. You want to turn down the immune system, but not too much. Just right, so that it's not attacking yourself and causing disease, but it's not putting you at risk for infection. That balance is not so simple. Most commonly, the first drug is everyone's favorite glucocorticoids or steroids, such as methylprednisolone, prednisolone, or prednisone. So these are the best drugs we have. These are the worst drugs we have, except for the insomnia and the psychosis and the cataracts and the glaucoma and the diabetes and the weight gain and the osteoporosis, the skin changes, the heart failure, the hypertension, and the infections. They're great drugs. And so, I think that we spending a lot of time trying to get people off glucocorticoids and not use them, but they work fast, they're cheap, and they still have an important role. I hope I'm not still saying that in 20 years. I hope I'm saying something in 20 years, but I think that but we are working hard, but they still have a role. Many patients with vasculitis will also go on with other immunosuppressive drugs, and I think that's to control disease. Actually, the majority of patients with the majority of forms of vasculitis are now being put on another form of immunosuppression, whether it's a pill or it's injection, other things. And there are many different classes of drugs. Increasingly, the choice is guided by good data from trials, but not always. I've been proud that our field in the last 25 years has done a lot of good randomized trials that really give us good answers. But sometimes we don't have that, and we have to do our best guess based on a variety of different things. And so that's what we're there for, to help you with that. So non-glucocorticoid drugs to treat vasculitis, there are a lot. They interfere with the metabolism of immune cells, such as methotrexate or mycophenolate or azathioprine. You may have heard these. I tend to use the generic terms. Drugs that block particular immune systems, anti-TNF drugs. Or these are things called cytokines, which are chemicals that go around and do all sorts of things in your immune system. We have drugs for every one of them. We have so many drugs now, it's amazing. But we have to test them, and they do different things. There's also these JAK inhibitors. These are pills. Many of these drugs have been used in other forms of vasculitis, and we borrow them. Other forms of autoimmune disease, and we borrow them. Sometimes they're first tested in vasculitis. That's been happening more in the last 10 years. Or drugs that block particular immune cells. You're going to hear about CAR T or cell therapy. We're a center for that as well, that block B cells or T cells. These are all different things. So the immune system, I'm going to give you a secret here. I tell this to our trainees. So the immune system, it's really complicated. And we don't completely understand it. And so that is, but we're learning more and more about it, and it's remarkably different understanding than we had before. But we try our best to sort of tackle it in very special ways. And so we've done a much better job of that. Drugs that block the complement pathway, you can hear about that, which is confusing. It's another thing. And then many other availables. The other thing to mention is most patients are on a combination of drugs, at least initially, and then we try to peel them back. So we're not afraid of combining drugs when it makes sense. And we know this from other diseases too. Rheumatoid arthritis, there are 25 drugs out for rheumatoid arthritis, and we combine them all the time. So, stages of treatment of vasculitis. So it changes throughout the year and throughout your journey with vasculitis. So the key concept is you may need different treatment. at different stages of different vasculitides in different people. So that's 4 difference in one statement, because it does vary. And you need to know where you're at and what makes sense for you medically and other things. So if you're a young woman who wants to have a child, who wants to start a family or continue, that's a different stage than that person's grandmother who doesn't have to avoid certain drugs and different things. Are you working? Are you not? And are you on fire? Is it terrible things going on? Or are you doing great? So we have to think about these. What are the stages? Well, induction of remission. We'd like to call it induction. So you're sick, you have active vasculitis. It could be new or it could be a relapse. We're going to induce remission. So we talk about induction all the time. You're going to hear about that all day long. Put the fire out, get the disease under control. That usually happens over a couple of months. We use pretty intense therapy to do that. Then, hopefully, you're in remission. What's remission? Remission is no evidence of active disease. You may not feel perfect. You may still have symptoms from the drugs or from what's happened. So if you had nerve damage to your hand, you may still have the tingling, but it's not active and getting worse. But remission is no active disease on or off drugs. And then maintenance of remission. How do we keep you there? That's the goal. That's the goal. And we want to keep you there, not just for a couple of months, but for a couple of lifetimes. And then, when can I stop therapy? And that is a happy problem. That is a good conversation. When can I stop therapy? Actually, I'm hosting a session during our conference this week, just asking that question. I have some expert colleagues with me, and we're going to sort of throw the question out there and see what people think. And I think it's controversial, but it's a good problem. But you can also end up not going into remission. That's rare, but it can happen. And then we need to rethink what's going on. You may relapse. The majority of types of vasculitis involves relapse pretty frequently. That's unfortunate, but we haven't cured these diseases, but we're going to try to, that's our goal. So relapse can happen, and then you need to get retreated. So when you have not in remission or you have a relapse, you need to re-induce remission, and you need a new strategy. I shouldn't say it, you don't always need a new strategy. You need to rethink your strategy. Not going great, what can we do differently? And then, so that's the stages. Monitoring your vasculitis, you mentioned this as well, I agree with this. So monitoring is key. The key concept is vigilance about your health is crucial to stay healthy. You really need to work with us to do this, and you are. So critically important to monitor for signals of new or relapsing or worsening vasculitis. Because what you really want to do is get it early so you don't have an experience of having damage or bad things happen. Partner with your provider. Work with him or her to get this. You are the early warning system. So you're in a very different situation today if you're a patient here than you were on the day you were diagnosed. Very different. Why? Because now you know you have vasculitis. Okay, you didn't really want to know that, but now you know. And so because you know, you can now interpret things as they happen in your body. Is this from vasculitis or not? I would say what you feel and notice, report them. The default should be send us a message through the portal, call, whatever it is you need to do to let us know. We will work with you to figure out, you know what, I don't think it's your vasculitis, I think you have the flu, which is also not good. Please get vaccinated. You're going to report how you feel, and we'll work together to interpret whether that's active vasculitis or not, or it's a side effect from therapy, or it's something else. You're going to be recommended monitoring. We're going to the signs or symptoms, et cetera. I'm going to keep moving. But observe findings on exam, laboratory tests, imaging, pathology, et cetera. The exact type and monitoring pattern you have to work out based on your disease and where you're at. So you need to address all aspects of your health. Even connection to vasculitis is not clear. And there's a lot in this program today to help you start thinking about that. So I'm going to tell you that you still should exercise. You need to think about your sleep health. You need to think about your mood. You need to think about the fatigue that is very common in vasculitis. And even though the doctors don't pay attention to it, I think it's inherently part of many types of vasculitis. Pain can be a problem. And so can weight control, because we give you these terrible drugs to make you gain weight. All of these things need to be treated. They're not all due to vasculitis, but vasculitis impacts these, and these impact how you feel with your vasculitis. Additionally, your other medical conditions if you have them. So it's complicated to do all this, but it's imperative. And I think there's some nice sessions about many of these aspects today. These are not instead of, they are in addition to other therapies. These are complementary approaches. Education and self-advocacy, key concept is knowledge about your vasculitis and your own condition is extremely helpful. And so empower yourself. I don't know, come to a session on a Saturday in Melbourne to learn about vasculitis. That sounds like a good idea. Learn about your type. Use reliable sources. So there's a lot of good and there's a lot of crap out there on the internet and just things that are just wrong. And so you've got to, how do you sort that out? Go to reliable sources. Vasculitis Foundation, I choose that because I work very closely. Joyce Kuhlman is the director for many years and is a great champion for patients. Vasculitis Foundation asks people like us up here to make sure that the information is accurate. And there are other sources like that, et cetera. Once you start, and there are medical sources, knowledge is good, but it needs to be good knowledge. Know your own medical history and test results. Know what you have. Now, the trouble with this statement is it makes people feel bad who don't know. That's not the goal. You got to do what you're capable of and what you're able to get. Some people come in with the binders and they have every test and they have it organized and it's like, wow, do you want a job? And so, and then some don't really know because they're not as sophisticated. They don't feel comfortable. Whatever works for you. But the more you have, the better I think you'll feel about how you're being taken care of. Keep track of what's going on. Even, I don't know how incredibly organized the electronic health system is. Is everybody on the same system?
We have My Health Record, which...
Yeah, so a lot of people are on Epic or something like that. Yeah, so that's great, but it doesn't always work. Be organized. It's okay to make a list of questions. It's okay. If your doc is not comfortable when you pull out a sheet of paper, you know. On the other hand, if you ask, you know, like what color should I paint my living room, you know, so there are questions and there are questions, et cetera. So, you know, what's up? You got to talk. You have to have the dialogue. And then advocate for yourself. But also realize it all takes time and can be over. This is overwhelming. So don't feel like you have to do everything at once. And don't feel like we have all the answers, because I got news for you. We don't. So this is what we talked about. You want to try to put it all together. It can be daunting, or you can take it one step at a time. And I hope this gives you a framework to think about for the next day of what we're doing. I want to just say one way to empower you. I was forced to use this slide. This was, I believe Joyce made this slide, which is, so you have some goodie bag, the Vasculitis Patient Powered Research Network. We'd love to have more members from Australia. We have some as ready. It's easy, you can use the code. There's a card in front. So this is blatant recruitment abuse that I'm using for my thing, and you're gonna hear from Dr. Gordon as well. So I'm happy to take any questions. I think I'll do that in the setting of the panel. I hope this was helpful. Thank you.
Thanks so much.
While they're setting up the panel, are there any empty chairs at any of the tables?
Yep. And also, if you've got any questions, please pop them down on the cards and pop your hand up, and then someone will come and pick them up and bring them to me. Finally, we're going to thank Peter for a wonderful talk, but joining us on the panel is also Kara. Kara lives in regional Victoria with her husband and children and has a lived experience of ANCA-associated vasculitis. So thank you so much for sharing your perspective today. I have got a few questions. Did I see...
You might want to give us a few mics.
I've got 2 mics. Firstly, Kara, can I ask you, how did Peter's talk ring true with you or not? What things did you take from that?
I thought everything he said was really relevant, actually. It put a lot of things into perspective. I guess we're always looking for answers and we're always wondering, can we ask this, can we ask that? It was good to hear Peter say, advocate for yourself too. I found that really, really good too. So yeah, no, every point I thought was really relevant.
Yeah.
Just be, you may get the answer is, I don't know. So that's okay. Sometimes we just don't know.
So one of the questions we had on the online was, thinking about warning indicators for relapse of vasculitis, and how patients can do that, or is that something they need to be talking to their vasculitis specialist about?
Yes, so the answer is yes to both, which is you need to know the warning signs. It depends on what type of vasculitis you have, because they really are different. But when you have vasculitis and you're being treated, you're going to think anything that happens to you, is that due to my vasculitis? That's not a crazy paranoid approach. That's reasonable to say, okay, I'm having this symptom, I'm having a cough, or have a rash. Is this my vasculitis? Is this from the treatment, or is this something else? That's a good place to start, and then you have to sort of sort it out. And I think, but the big ones, you know, basically, there's the same thing in general health, you know, cough, having trouble breathing. If yours is type of vasculitis that involves lungs, that's a problem. Blood, anywhere it's not supposed to be, is a problem. And there's not that many places it's supposed to be. And so that's always a problem. Redness or inflammation, whether it's your eyes, your skin, or something else, is a problem. New arthritis, new pain, new fever. Really, it's remarkable how many different things could be related to your vasculitis or related to your treatment. And that's what I think is important. And you need to be vigilant. Don't blow it off. Let us help you.
I think I echo that. And then sometimes it can also be very, very general. That's feeling not quite right. And I think those are important for us to know as well. Yeah, sometimes it's really hard for us to know whether you have is it vasculitis or something else. And we try our best with tests and things, but it is hard, but we have to work together.
I'll add 2 points. One is you may be recommended to get monitoring, blood tests and urine tests. There are 2 reasons to do that. One is to look for evidence that disease is back. The other is to monitor for the side effects of treatment. And so I think that's important. And I want to echo your point, which is how you feel matters. So we did a study several years ago where we looked in a trial and we asked patients what we call a global assessment. How do you feel about your disease? And what we found is that before a relapse, sometimes months before, patients started saying, I don't feel as good. And even before the doctors said, oh no, you're fine, we're not in relapse. And so you really are the early warning system. So if a patient tells me, I feel like I'm so great, I feel like how I did when I first had it, I was like, oh, that's not good.
You're nodding to that, Kara. Have you had that experience?
Look, I'm not, thank you, I'm not in remission as such yet. We're still getting there, I guess, trying to find my balance. I think my thing is, with the questions before, is even though it might not be the vasculitis that causes it, do you guys, I guess I'm asking my own question here, do you think that sometimes things that we can get generally, having the vasculitis doesn't help us heal as easily?
Go ahead.
Yeah, I think absolutely. You know, both from the vasculitis and the treatment that we give, certain things you're just not going to heal as well. You know, most obvious things that comes to mind, like things like infection. Yeah, but yeah, generally that's just and the fact that a lot of symptoms of different diseases can be very, very similar.
Yeah, so a drug like prednisone or prednisolone, other ones, do make it actually hard to heal certain things, or it masks what's going on. But you know, again, it depends on where you're at and what's going on. But it's a good question. You unfortunately still have all the other issues you may or may not have, and they may be interacting. So if you have high blood pressure, if you had it before you got vasculitis, you probably still have it. And if you're on prednisone or if you have kidney disease, that blood pressure may get worse, and so you have to treat that.
I have a question for you, Peter. In your career, have you seen an increase in vasculitis?
That's a tricky epidemiology question, Dr. Hill. So the answer, well, I've certainly seen a lot more patients. I think there is no great evidence that the incidence, or what we say, the rate of patients getting vasculitis has increased. However, there's a number of things that's happened in my career, which is now long, which is we have better testing. So ANCA was not actually available when I first became a physician. I remember when it came out. And so that's an example of, we have much better testing now, so we get more patients are diagnosed with vasculitis that might have died from it or not been diagnosed. More patients are getting diagnosed earlier, and more patients are getting diagnosed because of, you have a tummy ache and you go to the emergency department or A&E, whatever you call it, you got a CAT scan, all of a sudden they find something, they say, oh, maybe it's vasculitis. So yes, there are some types that may be increasing. So drugs can cause vasculitis, and we are seeing new classes of drugs that may cause vasculitis. An interesting one is, you've heard about these wonderful new drugs for cancer, so-called checkpoint inhibitors. They're great, but they actually trigger autoimmune disease. And so we're seeing a new group of patients with vasculitis. But in general, I think the answer is no, but since we don't exactly know what causes it, I always reserve the right to be wrong.
Someone's asked, can a relapse be confirmed by repeated symptoms only, or does it always need a test to be positive?
So I guess it depends on kind of what type of vasculitis you have. But I guess in the kidney world, we often we often confirm it with tests. But yeah, it does vary. You know, some types of vasculitis are quite different.
Yeah, I think we got to try to keep that back door closed.
Yeah.
So if someone could, now they're opening it. So let's close it so our people can hear. The answer is, I agree. So a couple of things. One is, sometimes we do base a relapse on how patients feel. So Kara, you know yourself, and if you say you're got bloody discharge from your nose and other things, and we don't think it's from an infection or something else, that may be enough. We do like to get other tests. That's a time, though, we do what remember I told you about cataloging and staging? New symptoms, we're going to look. So I think, we're looking for love in all the right places, and we hope we don't find problems, and you're looking. The other thing, and this is a tip, which many physicians don't always realize, that we publish data on this, which is just because you had X and Y and Z symptoms when you first got vasculitis, you can still have W and Q when you relapse. So new things can happen. I'm not trying to freak you out, but you just have to know that different things can happen.
Yeah. Kara, what did you find helpful when you first got vasculitis to find information about vasculitis, and where did you go to? Was it good or bad information?
Trying to think back. Honestly, the best thing I found, as much as Facebook can do your head in at times, was the support group on Facebook. That was where I really found my people, I think. I found my people. I found people that understood, apart from my specialist, who is wonderful, to actually understand a lot more was that Facebook group. That was really where I did gain more knowledge.
And that's the Facebook group that Mark Street...
That Mark Street in
Yeah.
charge of, I think. He's over there somewhere. So it's an Australian one. There are all different types of Facebook pages, but this one I found was a really good community where if you're having a bad day, you can say, I'm having a bad day, and people can relate. I know I'm very lucky with a very supportive family, but when you're having a bad day, you just feel like they don't understand it as much as they try to. So to be able to reach out at any stage to someone else that feels exactly the same way as you, I think is so important to have. So thank you, Mark, for doing what you do there.
I'm going to make it. So how many people here of the patients or have gone to social media to get information about vasculitis, right? Huge. And as you say, much of the time it can be very supportive and helpful, but there are times when it can be very intense, and it can be like, wow, these people have terrible lives. What am I going to, this going to happen to me? And so you have to sort of balance it. And I would say, not that you need but give yourself permission to not look if you don't. There are people who are Facebook, Instagram people, and the people who are not. It works great for you. That's great. It sounds like Mark may be doing a great job of hosting. Some sites are a little more free-for-all. So I'd be a little careful. And you can even, dare I say, go to American site. No, but it's, so I think it's, there's a lot of information out there.
So, as a clinician, what would you like your patients to show up with in terms of documentation and notes?
Cookies. No. So it's. I think that I think it's an interesting question. When I first see a new patient, I love information. Some docs, I want to see as much as possible. I'm good at sifting through records from the hospital, various things. Again, it depends on the location and how your healthcare system works. We have a more fragmented, what a surprise, healthcare system in the United States. So sometimes I have to get records. Increasingly, stuff is available on the computer we can look through. But you know what we really want? Whether it's whether it's your first visit or follow-up, we want to know what's been, you may take notes, what's been happening since last time, if you had any tests, a list of your medications, an accurate list of your medications and doses, and an accurate list and names of the other doctors involved in your healthcare. Those are very helpful. And you might want to take notes of things that have happened since then, because patients get kind of anxious at the visit and other things you may forget. Do you have any other?
Yeah, I think in New Zealand, electronic system is not bad. However, I still really like patients to come with their own things, and there are some patients who make graphs, which is excellent. But I think the medicines is very important. In New Zealand, because we can see all the medicines being dispensed by pharmacy in a way that could be a double-edged sword. I love people who come in with just a bag of the medicines that I could just see. And sometimes I'm like, oh, that dose is very different. I told you we're supposed to take 500, you're doing 250. Those kind of things are very important. And because of all the different contexts with different doctors, people may have changed things that we are not aware of. Yeah.
The other thing the other thing that can be very helpful is, again, I don't know the system. For me, I like to actually look at the CAT scan. I want to look at the imaging. So if you've had it somewhere else and I can't see it, bring it on a CD. Again, if you don't have it, come anyway, please. So it's okay. So it is, but it is it's good to have. Yes. So what's on the computer isn't always what you're taking, and patients have been known to not take meds. It's okay. We just need. But the worst patients, by the way, are physicians. Just to be very clear about that. But yeah, people don't always take it.
And I guess from an Australian point of view, I would encourage you to have a look at your My Health record. It really does have your pathology and your imaging on there. I know there was a little bit of scaremongering at the middle, and you might have decided not to do it, but I'd really encourage you to have a look at that, because it will list your medications and your pathology, blood test results, and your imaging as well.
And actually, if you're scared about something, we can help you get unscared about it.
Yeah,
it's like,
totally.
oh, why is my AST, 37, but the top normal is 34? It's like, it's fine.
Yeah.
And sometimes you worry all weekend about it. So,
Yeah. While you're here, Peter, I'll just ask you this one, because you've also got a research interest in scleroderma. How does scleroderma relate to vasculitis? When does that happen, and will it happen?
So scleroderma is another disease you don't want to get. It's an autoimmune disease. It involves hardening of the skin, and it can cause scarring and inflammation of the lungs, occasionally the kidney, heart, other areas. It causes Raynaud's. Lots of different things happen. It's another disease of the immune system attacks. It is very different from vasculitis. There are some similarities across many autoimmune diseases, which is very fascinating scientifically. It is rare to have both. Because I see a lot of patients with both, I have patients with both, not a good combination. Although patients with vasculitis are more likely to have other forms of autoimmune disease, it's not that common to have something else. Thyroid disease is common, for example. I wouldn't overly worry about getting another big thing. Similarly, you may ask, your family members may be more likely to have autoimmune disease if you have it, but not to the point where anyone should be tested for the most part for genetically, et cetera. So it's not a big overlap, but it's not good. You are allowed to have more than one disease.
He's very reassuring.
I don't recommend it, but I'm just saying.
So this is to Tze and to Peter. Have there been a case where a patient has made a full recovery from GPA?
I would say yes. Yeah. I mean, from my view, yes. We're all asking about cure and things, but actually, sometimes I like to put it into a big picture perspective. If I'm just going to use the kidneys as an example, say you're 70 and your kidney function's 30%, you get 90, I could keep your kidney function at 25, job done, you know? Yes, you still have kidney impairment, but, you know, we've reduced the damage enough that you don't need any further intensive treatment. See, so there is kind of perspective, the big picture stuff, the how you feel, what at the end of the day is important, more so than the numbers, I would say. So that's my view of it. I do think that we have people who can present really severely with GPA at the beginning, severe kidney disease, and we could sometimes kind of reverse that to a certain extent and then maintain it for the rest of the life.
I agree with all that, although you're more than numbers. The kidney numbers matter a lot. Absolutely, there are patients with GPA and every form of vasculitis you'll be hearing about today who have it once, one and done. The trouble is, first of all, it's the minority of patients, that's to be clear. And second of all, you don't know you're that patient until you've been followed for years. I actually like to say, for most forms of vasculitis, I'm following patients forever. And you know what? When they come in, I call it the well baby visit is great. Like, I feel great, let's talk about my grandkids, it's great. But sometimes, even 5 or 10 years later, someone says, oh, and by the way, I'm having this. It can be a relapse. So somewhere between being very happy that you're doing well and going crazy is where it's at. But there are definite full remissions after one course of therapy in multiple types of vasculitis. It's not as common as we want it to be, and our goal should be to cure these diseases so that we don't have to ask this question anymore. And we should get there.
Yep. Thanks, Peter. We're nearly time for morning tea. We've had quite a few questions. Some of them are more related to specific types of vasculitis, so I'm going to these questions won't be wasted. I'll distribute them to some of the other presenters. But there's just one more that I would like to. I'd really be interested in both Kara and Peter's thoughts. How do we shorten the time for patients to become well-informed and develop a team? Sometimes it feels hard to get going when you've got new disease, there's lots of stress, you feel a bit clueless and harassed.
I completely agree. There's so many aspects of it because your whole world feels like it's been flipped upside down. If there... In a perfect world, it would be great to have somewhere that we could be directed to that has everything, things like different strategies people can try outside of the realm of being a specialist and rheumatologist, you know, the nutritional side, nutritionists, psychologists, even down to yoga instructors or personal trainers that can all help you. I guess I found you need to develop your own team. Would you agree, Peter? I totally agree. Yeah, if you can develop your own team, but that's hard to do when you don't know where to start. So if there was something we could go to sort of list different things of how we can start. Also things like financial trouble too. It does take a financial strain on a family when your life is turned upside down. So those things I think are hard to find out as well, and where I think a lot of us struggle. So somewhere we could have to go for all of that information, just even touch points would be great.
Yeah, I agree. I mean, but I think you need to also give yourself a break and realize where things are at. I don't have vasculitis, but I've been clueless and stressed out my whole life. So I think that you need to work what's right for you. And I think, this kind of meeting and the resources that are being outlined, et cetera, are very helpful. You don't have to get there tomorrow, but you have to you want to improve, you want to get the information. And I don't think there's going to be one source, just as there's not one answer, and things keep changing. So you can throw your hands up, oh my God, it's so much going on, or you could tackle one thing at a time and figure out what's most important for you. And I think that dialogue with your family and your friends and your physicians and your nurses is really what makes it right. And I would, I think we have a tendency, we we are both trying not to scare you because there are bad things happen and then you can get a little freaked out. But I will tell you that there has never been more research being done in vasculitis in history than there is now. And you have 1,000 people coming here to this meeting that Dr. Hill and Dr. Kitching and Dr. Quimby have organized. It's just amazing. So I think things continue to get better. We learn more. So let's work together and make it even better.